Today we will be discussing on MME 102 and MMEL 102, that is related to obstetrics and gynecology of PGDMC's program. To discuss the issues, we have three experts today. To my right, Professor Sunesh Kumar. He is professor at All India Institute of Medical Sciences. He has been involved in our program as a course writer and also editor. To his right, Professor Chitra Raghunandan. She is professor at Lady Hardinge Medical College. She is also involved as a course writer and editor, and also has been involved as a counselor for the PGDMC students for last 5-7 years. And to the extreme right, Professor Gauri Gandhi. She is professor at Maulana Azam Medical College and also has been involved as a counselor. Dr. Gandhi, in the antenatal care, what are the things we have to check for the pregnant lady when she reports?
Actually, if antenatal pregnancy has to be very monitored in a detailed manner, then in the first trimester she requires to be checked up once every 4 weeks, up to 28 weeks, once every 4 weeks, then every 2 weeks right up to 36 weeks, and after 36 weeks she needs a checkup every week. Basically, we do a history taking, a detailed history taking, a general physical examination and obstetric examination. In the history taking, we have to take the history of present illness, that is regarding her present pregnancy, amenorrhea, how many weeks of amenorrhea she has, if she has any complaints at the moment, and ask her specific questions regarding those complaints. Then we have to take her past history, her past obstetric history, her past medical history, family history, social history. And general physical, we have to do all the things required in general physical examination: pulse, blood pressure, edema and pallor are 4 important things in pregnancy. Apart from that, we must check for lymphadenopathy, cyanosis, koilonychia, all the general parts of general physical. Then we do a systemic examination to see for any thyroid enlargement, examine her cardiovascular and respiratory systems, and then do an abdominal examination. The obstetric examination in detail involves inspection, palpation, percussion, auscultation. So when we do inspection, we see how high the height of uterus is, whether there are any hernial orifices which can become prominent during coughing, whether she has any scar marks, very importantly, whether it is because of a previous cesarean or any other surgery. And then we do the obstetric palpation. It involves 4 grips, as your books have described. First, you have to do fundal height of the uterus and see whether this corresponds with period of amenorrhea, which you have calculated from her last menstrual period. Then you have to do the fundal grip, the lateral grip and the 2 pelvic grips. The idea of these is to see the height of uterus, the lie of the baby, the presentation of the baby, and whether the fetal heart sound is well auscultated or not. And if it is not corresponding to period of gestation, then it can be either large for dates or it can be small for dates. The uterus may be smaller than period of amenorrhea. Each of these problems has some reasons which we have to then go into detail. Auscultation of the fetal heart sound, we know the normal fetal heart sound is between 120 and 160 a minute, and we can hear it where it is located near the position of anterior shoulder. After doing the abdominal examination, then a pelvic examination is indicated at certain times in the pregnancy. When she makes her first visit in first trimester, then one can do a pelvic examination to judge the size of the uterus. We have to inspect the cervix for any abnormalities, that's important in speculum examination. Then a bimanual pelvic examination to see the size of uterus, whether it corresponds to a period of amenorrhea, and the condition of the cervix, and also if there are any masses palpable in the adnexa. Then the pelvic examination is indicated in normal pregnancy only in the primigravida near term to see whether her pelvis is adequate and her cervix is favorable. Otherwise, pelvic examination is indicated only in specific situations. Supposing she has labor pains, she has got leaking per vaginum. It is not to be done when she has history of bleeding per vaginum in late pregnancy. Then pelvic examination has to be avoided and ultrasound has to be done to locate the placenta. After the examination, then certain baseline investigations are given to the patient on her first visit. These include the blood group of the patient, the hemoglobin, the carbohydrate gestational intolerance, and the testing for syphilis, the VDRL test. Urine sugar routine microscopic has to be done, and these are baseline for all pregnancies. Plus, if she has some specific disease, then investigations accordingly. If she is hypertensive, then her kidney function tests and urine culture and urine examination has to be done. If she's got a thyroid problem, then her thyroid functions have to be done. But the basic 4 investigations we have already listed. Then after that, when she comes on every subsequent visit, we have to see her weight. We had noted her initial weight, what her weight gain is, what is her urine albumin sugar, what is her blood pressure examination, and what is her whether she is anemic or not, because anemia is very prevalent in our country. And then we further do the obstetric examination at every visit.
Dr. Chitra, can you just tell us that because most of our objective is to handle the patients in a peripheral situation, so in a PSC for example, is it essential that we should include as a routine ultrasound examination for patients?
The ultrasound examination, if the facilities are available, even now even the villages, districts, primary health may be having the ultrasound facilities, but majority of them may not have this facility. Just a clinical examination at this time is sufficient, I feel, and if need be, if there is a need for an ultrasound, they should be referred to from primary health center to a district hospital or to a tertiary level hospital. But otherwise, as a routine at a primary health center, the medical officer who examines the patient in the first trimester has to do a first pelvic examination, and in the after 12 weeks she can palpate the uterus for the growth as the period of gestation progresses, and then the clinical examination itself may be sufficient. So but for special interest, then we can refer.
Yes, madam. Can you guide our students that when they will suspect that okay, ultrasound is essential, so that at least even if there is no facility, they can refer to nearby centers?
If the patient has come with some history of bleeding in the first trimester or pain in the first trimester, a clinical examination, you are doubtful that she may be carrying an ectopic pregnancy. So this is the time when she can refer the patient to immediately to the higher center for further evaluation of the patient if she is suspecting a threatened abortion which she cannot manage at the primary health center, or ectopic pregnancy. Naturally she will not be able to manage at primary health center, so she has to refer this patient for ultrasound examination at a higher center. Apart from that, as the pregnancy progresses, the second from 12 weeks to 20 weeks, she should be able to appreciate fetal parts, she should be able to take out history of fetal movements appreciated by the patient, she may be able to listen to the fetal heart. And in this situation, if she is not able to appreciate fetal parts or fetal movements, external allotment she is not able to detect, then she may suspect a molar pregnancy. At this time also she should refer this patient to a district hospital or to a higher center. Then in the third trimester of pregnancy, as the pregnancy advances, if the patient has any complaint, has bleeding or symptoms of high blood pressure is recorded by her after 20 weeks of gestation, then again there is a question of referring this patient if she is not able to manage this patient at primary health center. Then abnormal presentations, abnormal lie of the fetuses, if there has been any history of bleeding in the third trimester, this patient should be again referred. So the idea is to select cases who are high risk situation in pregnancy, and these patients should be timely referred for further investigation and management at higher center.
Dr. Gandhi, will you like to tell us that okay, now our doctor in a primary health center, what are the danger signs he can identify so that in the antenatal care he can take care of those things?
First of all, on general physical examination, you have to see, I said, very important disease in our country, prevalent widely, is anemia. So you have to look at the patient to see whether she is pale, and that will give you a good indication. You can even judge whether the pallor is mild, moderate, or she's got a severe degree of pallor. So severe pallor is a danger sign. Leaking, there's vaginal bleeding at any point of the pregnancy. First trimester, like Dr. Chitra said, it can be threatened abortion. Leaking per vaginum in the second trimester or third trimester before she goes in labor. Abdominal pain at any point of pregnancy. Decreased fetal movements. Now the patient starts feeling fetal movements only after about 20 weeks of pregnancy. The primary feels it maybe at 22 or 20 at about 22 weeks of pregnancy. If she comes to you in second or third trimester saying she has no fetal movements or decreased fetal movements, that's a danger sign. Persistent vomiting, this goes back in the first trimester. Persistent vomiting can indicate hyperemesis gravidarum or the presence of molar pregnancy. Then you have other signs like severe headache. This can be a sign of increasing blood pressure. Then a lot of pedal edema which is not subsiding on rest, and also fever, chills, or any other infective illness. All these should alert you. Plus the presence of lot of edema, lot of high blood pressure, or symptoms of vomiting and headache, as we have already said.
Dr. Sundesh, will you like to add that for our doctors in the primary health center, so we have discussed the danger signs and maybe referral. Will you like to add that, okay, what are the situations when they should take special precaution and promptly refer to a bigger setup?
In addition to what Dr. Gauri Gandhi and Dr. Chitra has said, if on the basis of history she had repeated abortions, or she had stillbirth, or she had required instrumental delivery, this is another situation where this pregnancy becomes high risk. On examination, if we find her height is short, she is 4 feet 8 or 9 inches, her gaits is abnormal, which means that there may be some abnormality in the pelvis. If on examination we find she has protuberant abdomen, pendulous abdomen, which gives the idea that her pelvis may be small, or if you find she has multiple pregnancy, or if she has a malpresentation, in this situation it is better that we refer such a case where there are facilities for operative delivery and blood transfusion. So maybe we can refer her to FRU or to a district hospital. If a patient has jaundice, a common problem which we see in our country, she is at a high risk. When she has jaundice, she may have premature delivery, she may have excessive bleeding during delivery, she may have stillbirth, and she herself is at a risk of losing her life. So such patients are again better managed at a better or a larger hospital. Heart disease is another problem, not uncommon. Almost 1 or 2% of pregnant women may have heart disease, and surprisingly we may for the first time in pregnancy discover that she has a heart disease. So again, this patient should be in a center where there are facilities, where there are physician, cardiologists available, and she can be looked after well during delivery and in antenatal care. These are some of common condition which we tend to face in our country, and in such situations she should always be at a place that she can be easily managed, better managed at the time of delivery.
We have discussed in detail that what is the purpose of the visit and what are the risks you have to look into so that the patient is referred in time and all the investigations are done in time. You already know that a patient in a periphery, he or she should visit the primary health center ideally once in every month up to 7 months, and then twice a month up to 36 weeks, and then at least one visit per week. But it doesn't become possible or feasible for all the pregnant ladies. But what Government of India expects that at least there should be one visit before 20 weeks and one visit at 32 weeks and one visit at the 36 weeks, so that all the pregnancy related complications are detected in time, and mortality can be prevented. Dr. Gandhi, will you tell us that okay, when they give the visits, what is the main purpose of these visits? For example, patient comes at 12 week to the primary health center for diagnosis of the pregnancy and other things. What are our main purposes?
The first thing is she comes to you with a suspected pregnancy. She gives history of amenorrhea. So you have to ask her that history and confirm that she is pregnant, because there can be other causes of amenorrhea. So the first visit, when we say at 12 weeks, is recommended. The main purpose of this visit, as is shown, is you take the history and confirm her period of amenorrhea. You do a pelvic general physical and then pelvic examination to confirm the size of uterus is corresponding to period of amenorrhea, and she doesn't have any lesion in cervix and adnexa. Then you give her baseline investigations we have already listed: hemoglobin, blood group, urine, and the STS, and look for any high risk factors. These we have already enumerated. I will quickly say, in the history, she could have history of medical disorder like heart disease, diabetes, hypertension or epilepsy, and she may have other medical or surgical illness in the past, plus risk factors of a previous obstetric history like previous stillbirths, previous abortions, previous cesarean section. And after this, you have confirmed her pregnancy, ruled out risk factors, given basic investigations. Then you give her this advice that you come with these reports if she doesn't already have them, and report after 4 weeks. In the meantime, you also tell her if she has any bleeding, leaking or pain abdomen, she comes to you during that time. Then we do the further management in subsequent visits. Every subsequent visit, she must her weight is taken, her blood pressure is taken, the urine is checked for sugar and albumin, and a obstetric examination is done to see growth of uterus, whether it's corresponding to period of amenorrhea, what is the lie of the baby, what is the fetal heart rate of the baby, movements of the baby are normal or not. So, and now the advice comes regarding iron prophylaxis in pregnancy. That's very, very important. Diet is the first thing. She has to add 300 kilocalories per day, and in lactation about 550 kilocalories per day. It should be a balanced diet with adequate carbohydrates, proteins and fat. She must be made aware of personal hygiene and have adequate sleep, exercise, avoid alcohol, smoking and any drugs without supervision. Some drugs are completely contraindicated in the first trimester because they can cause teratogenesis, and some drugs are to be even avoided in later pregnancy, so that she has to consult the physician before indiscriminately taking any drugs. And then regarding her iron prophylaxis, she has to be, the ICMR recommends 100 milligram of iron for at least 100 days during the pregnancy, given to all women, because most of our women are not at the ideal level of 12 or 13. And so anemia prophylaxis, since it's present in 50 to 60% cases, and the commonest deficiency is iron folic acid. 100 milligram elemental iron and 500 micrograms of folic acid is recommended. And of course, if she is nutritionally deficient in other substances, those have to be added on. Tetanus toxoid prophylaxis is given. The first one at 16 to 20 weeks, the second one between 20 to 24 weeks, and with a minimum interval of 4 weeks. And if she has been immunized in the last 5 years, then she only needs one booster dose. Plus we do testing for VDRL, and HIV is now recommended as a universal testing. It's not yet implemented for in all hospitals, but I think it is becoming important. Plus if she has history of any genetic illnesses in the family.
Dr. Chitra, will you tell us that for example TT we give 2 doses in the primary, and or there is a pregnancy after 5 years or so. How frequently, for example, one takes a booster dose in the second pregnancy, what is the best time to give?
The first dose of tetanus toxoid is given in the around 5th or 6th month of pregnancy, that is after 20 weeks of gestation, and after about 4 to 6 weeks we give the booster dose. But if the patient has a subsequent pregnancy within a year or so, then we need to give only one booster dose for the same.
The main purpose, as you know, the main purpose of giving TT in pregnancy not only to save mother but to
also
prevent
to
neonatal tetanus. Yeah.
Yes.
So
at least if the patient has not had any antenatal checkup till late pregnancy,
yeah,
if you have a 4 weeks gap, at any time she comes, she can be given this tetanus toxoid, and after 4 weeks booster dose should be given.
Okay, now we have a fair idea about the antenatal examination and how to do the important investigations in the periphery.